Assalamu alaikum. My name is Nasir Tanauli. I am an anesthesiologist and intensivist, and topic of my discussion today is critical care in elderly and end-of-life discussions. Brief introduction is that older Americans, which are 65 years and older, are expected to double in population from 46 million to over 98 million by 2060. With proportion of this age group increasing from 15% to almost quarter of the total population. And because of that, we are seeing an increased age component in our ICUs of critically ill patients. There are geriatric syndromes and their associated comorbidities. These terms are called geriatric syndromes, including which are pressure ulcers, incontinence, falls, functional decline, and delirium. And presence of these syndromes may contribute to ongoing higher level of nursing, care needs, decreased independence, reduced quality of life, and critical illnesses. Aging is also associated with increase in comorbidities or the co-occurrence of two or more chronic syndromes or diseases. The common comorbidities in aging are hypertension, diabetes, chronic obstructive pulmonary disease, heart failure, cancer, and cognitive impairment. And I'm sorry. Yes.
Okay, now it's working.
I think so.
You have to,
Keep
they're
it.
not in synchrony.
Okay, that's fine. Okay, start moving again. So here we go. So as I was mentioning, that hypertension, diabetes, chronic obstructive pulmonary disease, so on and so forth. Frailty is another syndrome resulting from decline across multiple physiological systems that decrease the body reserve for managing stressful events and increasing vulnerability to adverse outcomes. We have seen over and over again that a younger person being exposed to similar kind of trauma or illness bounces back much faster and much better way, almost to normal, as compared to anyone who is elderly, and they get into multi-organ failures and multiple problems, despite of having the same starting point of any disease or a trauma or a condition. This is a little chart which tells about different organ systems which are affected differently. Mainly in central nervous system, your white matter volume is decreased as compared to gray matter with the age. And white matter is very important, obviously, with connections and your cognitive impairments and so on and so forth. Your cardiovascular system is affected. You have more resting sympathetic tone, decreased vascular and myocardial relaxation. Kidneys are affected. Respiratory system is affected. You have higher aspiration risk. You have decreased respiratory responses to any of your conditions coming. Your immune system is affected, and your musculoskeletal system is affected. So, here we go. All these conditions lead to another condition called multi-organ failure. You come with one problem, which is pneumonia, and then the general effects of pneumonia leading to sepsis, leading to hypotension, leads to multi-organ failure. Your kidneys are affected, you'll go into shock liver, and pretty much all the organ systems go down. If someone has more than 3 or more organ systems affected, and they need support on that, your chance of survival are less than 1%. If and when we are able to get our older population out of ICU, their story is not still done. They still have post-intensive care syndrome, and long-term outcomes are affected. They are physically disabled, they have physical disabilities, they have neurocognitive deficits, psychological syndrome, and overall long-term outcomes are affected in worsened conditions. After all this, another very important point comes in, which is ethics and end-of-life discussions. As we are aware that in our culture and bringing religion in it, it's almost a taboo to talk to our parents about end-of-life discussions. So in ICU, along with defining goals of care, a code status, which is what happens if your heart stops. And end-of-life discussions are valuable to ensure care teams and families are communicating and informed on risks associated with acute illness, as well as life-sustaining interventions, regardless of patient status on admission. Care team, including social workers, case managers, interpreters, religious members, and palliative team members, can be helpful in aiding and facilitating these conversations within the hospital settings, and these ancillary teams are readily available. Life-prolonging interventions, they may not improve quality of life, should be discussed to delineate patients' goals of care, may include mechanical ventilation, eternal feeding, tube placement, TPN, and tracheostomy. Someone walks in with multiple problems and have compounded that situation by another problem, the discussion comes in. And this is part and parcel of ICU discussion, that what are the goals of care, what we're trying to achieve. A person who has a massive stroke with no signs of coming back to any proper life or being disabled for the rest of their life is a very difficult situation for any family, especially when it comes down to your own parents or your loved ones. The concept of withdrawing care, concept of not moving forward, it is such a difficult decision that it has to be very clearly articulated to the family members and the people who are taking care of. We're moving forward. Okay. There we go. This is a little chart. You see a little doctor standing on a side thinking about what to do when the person has acute illnesses. I can. Okay. So we'll just move on. We talked about this already, so we're gonna. So as a summary and conclusion, increased age of population means there will be increased demand of specialized geriatric care across medical and surgical specialties, including in ICU. Aging affects multiple organ systems, and these changes must be considered when caring of these patients. The multi-organ physiological effects of aging, in addition to other complexities associated with geriatric patients, such as frailty and pre-existing comorbidities, all must be considered and incorporated in the greater holistic approach for caring of these patients in ICU. Lastly, I think for us it's very important that we should engage in discussions with our elderly that what would you do in time when they can't make a decision? What if they have a condition which is totally non-reversible? And how they would like to handle that. Because in my experience, we have seen that it fractures families. The brother is against brother. When one says we should stop, another says we shouldn't. And that put an unnecessary pressure on the families. So having this discussion up front would be something which all should consider. Assalamu alaikum warahmatullahi.